today's session, which, as I mentioned at the start, will have 3 parts. We'll start now with the first part, where Dr. Claudina Cayetano, who is our mental health advisor, will be sharing with you the key concepts of the IASC MHPSS framework. We'll be able to explore what are the core principles and some of the best practices in implementing this approach, both in the Caribbean and elsewhere. So without further ado, I would like to invite Claudina to take the floor and walk us through the IASC model. Claudina, over to you.
Good morning, Dr. Prieto. And the protocols being established, it's a pleasure for me to be part of this partnership. And as my last slide will say, there's, mental health is everybody's business. So I'm really pleased to see that we're focusing on this. We have this partnership to be able to strengthen mental health in the region. So I'm going to be sharing with you my slide. Great. Okay, so my presentation as mentioned by my colleague, Dr. Prieto, I'm going to be talking to you on the IASC guidelines, the MHPSS aspects of the COVID pandemic and the model of MHPSS coordination, what are these recommended interventions in MHPSS, and some resources that we have. But first I want to take you for a moment, I want to take you to 2020, to the beginning of 2020. If you remember, I don't know where you are, but I'm sure you were with family and friends and celebrating. And we have, sometimes we have this tradition where we have 12 grapes, for each month you have a week. So you plan for 2020, you had personal plans, professional plans, and, plans with your family and things that places you want to visit, maybe different plans. And I bet you never had any plans to be experiencing COVID. That's what this is happening to us. So of course, additional to that, we had, and so then in March, just 100 days, sorry, just 100, someone has a mic. Can you please mute your mic? Okay, thank you. Just over 100 days when we're starting off the 2020, then our Director General announced on March 11 that this is a pandemic. We have then, so now I don't think we actually captured the meaning, because most of us who are at this stage of our life, at least I don't, we never experienced something like this. So he said, prepare, be ready, detect, protect, and treat. And so now we know we are now in a pandemic stage. This is in March. So this is when I think and I bring you to this because I think this is, when you hear these things, it does have an impact on your mental health. Makes us anxious, the uncertainty, the not knowing what to do, and how, the rumors and so many things happening. So this is why the relevance on mental health, because it has an impact on the mental well-being. That uncertainty, people sometimes don't sleep, don't eat well, they get stressed, or they eat too much, too little. The stress and the anxiety about the unknown. So the mental health and psychosocial aspect is of a pandemic is extremely important. And here is when we're talking about the IASC guidelines. So the IASC, the Interagency Standing Committee, there's a reference group for mental health and psychosocial support. And what it does is that it's a group that brings all the humanitarian agencies together. So Red Cross, WHO, IOM, all the... So I'm explaining what is this IASC reference group. So it's a reference group, it's a group that brings together all the international humanitarian actors. And they have, for emergency response. So clearly, too, for this pandemic, they developed a briefing note, specific for COVID. But when it comes to this, and when we talk about MHPSS, which is the mental health and psychosocial support, it's not just mental health. It's bringing actors that are in the social sector and the health sector together. Because as I mentioned, this has an impact on your mental well-being. And it provides an overarching principle. So the preparedness, we're talking about what it is that needs to be done to be able to be prepared. So they have this overall principle, which is a coordination so number one is the coordination to stop the transmission and prevent the risk. Clear coordination in terms of meaning integration of all the humanitarian actors, that the response that we need to provide has to be a response that is grounded into the local context, adapted to the health needs. And first of all, we need to make sure too that we are providing services that are providing hope, safety, empathy, social connectedness, self and community efficacy, that all of these have to be invaded into the intervention. People want, when we talk about the public health measure in terms of the social distancing, people still need to be connected. So emotionally, so providing that empathy, the social connect is very important. Local actors need to be supported with both accurate knowledge and facts about COVID. And we know there's always a lot of rumors out there, which makes it very difficult for people sometimes to manage all that information. So important to guide people in terms of, to diminish the rumors, get the information from reliable sources. We don't have a vaccine as yet, so clearly that also, heighten the anxiety people are experiencing. Now we do have, prior to this pandemic, we have people who suffer from mental disorder. We call them MNS, like mental health substance use disorder, or people with psychosocial disability. They still need to continue with their treatment. So this is what we call the overarching approach to MHPSS. So all of these principles are very, very important. So this slide, as you see here, we have from PAHO, we had developed this publication a few years ago, which is the publication on mental health and psychosocial support in disaster situations in the Caribbean. So there's a framework on page 4 or 5, and that's where I took this model. And why this model? Because this is nothing new. I think we have been introducing this model for so many years, and precisely because of the challenges at the time, as it was mentioned by Ms. Shutele, when it comes to, we are now in the hurricane season. June to November is the hurricane season, in the Caribbean, and now we have to be preparing, during COVID, but we already. So MHPSS means it's not just for COVID, it's also for the emergency, because we're talking about mental health and psychosocial support during disaster situations, so the same thing with the pandemic. So I took this model because I think it's very relevant, it's still very relevant. If you look at that publication in terms of when you think of the humanitarian, the coordination of efforts, that when it comes to mental health, MHPSS is a cross-sectoral working group. So you have focal points in each of the sectors that are accountable for the mental health and psychosocial well-being. MHPSS activities, so it has to be relevant in every chapter, in every sector. So it's not only the role of the health sector, it's also the role of protection sector for child protection, gender-based violence, for education, for nutrition. So it's a cross-call. So we need to make sure that it's, we call it cross-cutting. It's intersectoral. Mental health is not, psychosocial support is not only for healthcare providers. Because we listen or we hear the word mental health, we think of mental health professional, but that is not the case, because we want to make sure that here everyone has their, their needs for mental health. So protecting the mental health is very important. So this is why I thought it is so relevant that when we think of when we are in this season, we still find this to be relevant to make sure that mental health is cross-cutting, is a working group, that in every sector, every response, you should have a focal point for mental health support. So there is also a MHPS, a global group called MHPSS.net, the Mental Health and Psychosocial Support Network. And if you in your web page, in your Google, you put MHPSS.net, you will probably can log in and get connected and learn more about what is happening from global level. So it's a global platform for connecting people, network, organization, to share resources, to build knowledge, everything that is related to mental health and psychosocial support in emergency situations. But not only in emergency situations, even in situations that are chronic hardship. So it's a network that is functioning online, and so it's a community of practice for MSPSS. So it's important. If you get a chance, I think it will be good if you want to learn more about HPSS network. This is a good one to join. When it comes to PAHO objective, in this pandemic is save lives. Have two objectives: save lives, protect healthcare workers, and flatten the curve. Communication, media, it's a cross-cutting issue, and similarly, mental health is a cross-cutting issue. So from mental health, we develop in line with the ISC guidelines. So we develop there's this recommendation for mental health and psychosocial support during the pandemic. And so this document, what it does is that provides essential guidelines or interventions, how to support, how to provide its provide countries, how to support countries in developing their MHPSS. So it follows the frame of reference, the framework is of the ISC, following the pyramid of intervention. And the thing about the pyramid, as you will know, and most of you probably familiar with that, is that the pyramid has different levels of support. So, and that the different levels of support that ranges from social consideration, safety and basic needs to provision of specialized services. So here what we're saying that not everyone will need that. That's why it is in a pyramid and it's in levels, because not everyone will require specialized services. Some people may, some people may not. But the most important thing is that the aim of this guideline, this intervention, is to reduce suffering, improve mental health and psychosocial well-being of people who may be directly or indirectly affected by the pandemic. So here what we're looking at is, in this pyramid, we want to protect people's mental well-being. When you're more calmer, more relaxed, when you learn how to take care of yourself, it's easier to take care of others. So this is what we want to be able to be promoting, mental well-being. So this is why it is in a pyramid. And I also wanted to bring to you, this is like when we do presentation, we always have different slides. So this is not my slide. This is a slide from the school mental health literacy program that we have, because it's a mental health literacy. So it talking to people to build their literacy on mental health. And I really like this slide, and so I thought in including it here. Why? Because I think it's important, the language important. A lot of what happens when it comes to stigma had to do with the fact that people don't feel comfortable talking about mental health. And even though we are saying mental health matter, you need to be able to feel well and comfortable. But when we say the word mental health, sometimes people tend to confuse with mental disorder. So, and this program uses the same language, the same pyramid in terms of the interventions for the ISC guideline. So when you look at the pyramids, here at the base of the pyramid, we talk most people, you can be, you may not be, when you're happy, when there's no distress, there is no problem, you're okay. On the second level, people, that same similar, I should look at the other, but you will see it with IAC guideline pyramid, that people, when, sometimes we get annoyed, we get upset, we get unhappy, something can be, we get disappointed, angry, bitter, and that's not a disorder. It's a distress that, because of the external situation, so it affects how you're feeling about at that moment. But then, you become negative, despondent, pessimistic. That is transient, is you're responding to some external factor. Then, of course, sometimes, we have some very painful situations happening in our life when you become demoralized, heartbroken. So, then we could use the word problem. So that could also cause problems. But when you have a mental disorder tends to affect your function at work, at home, or at school. So that is different. So then we talk about the disorder. But look at the different levels before we get to that, and not everyone experience mental disorder. So I thought language, I'm bringing it here just because of language matters. So you can be distressed, you can have a problem, but that doesn't mean that you're having a disorder. So I think it's important for people to manage, I think it's relevant because that makes it easier to seek help, to look for support. So if you think of the mental health, the ISC guideline, so the ISC guideline, as I mentioned, has 4 levels of care. So the first level is social consideration in basic services. Then the second level is to strengthen community and family support. And the third level is focusing on the person. And the fourth level has to do with the specialized services. And I think it's important. What happens is that when people think of MHPSS, they're immediately thinking about mental health professionals, and that is not the case exactly. This is what we are saying here, that here we want to be able to, if you think of general consideration, we want to make sure people have basic, so this general consideration is ensure that their basic needs are met. So what are these basic needs? So we're talking about water, shelter, things that are relevant for us to be able to survive. So this is definitely very important for us. And it's targeting general population. And we want to make sure there is a respect to human rights. We want to strengthen the dissemination of information, ensure access to reliable sources of information. So this is what is consideration here. So for example, for this pandemic, we're talking about, the public health measures. We're talking about hand washing, 6 feet apart. We're talking about social distancing, all of those things that, using a mask, protecting ourselves. So this is for general consideration. This is target group, it's all of us. The hurricane is coming, so we need to be prepared. And how do we prepare? By listening to the radio, by the warning sign, by having enough food supply at home, knowing how our family can find where we are. All of those. This is general. This is why we need to do this, because we need to stay calm. It's peace of mind. It brings peace of mind when you be able to have the correct information. So what are the interventions that we're looking for? We're looking for intervention in terms of identify organizations that will provide services, good coordination, dissemination of reliable information, and who are the people that are involved in this first level? Local authorities, community teams, first responders, civil society, NGO, journalists, the media. This is what is the first level is about. So if you notice, you're not talking, so it's psychosocial support, yes, but if you're not talking about mental health, we're talking all of us, because what this brings is a peace of mind. So it's the coordination in the emergencies, the importance of this first level of care. So we go to the second level. So when we look at the second level, so clearly here we are looking at strengthening. So here is strengthening community and family support. So when we talk about strengthening community and family support, the considerations that has to go is that we want to address the psychosocial impact of people and family that can be affected, people who have high risk factors, address the impact of disruption to cultural and meaningful practices. For example, in this situation, death and mourning, people don't do the burial like they used to do before. So clearly you have a specific considerations for the second level, and you also have target groups and you have intervention. So when we talk about this General considerations, we want to address the psychosocial impact of on people and family, address the impact of disruption, identify what are these risk factors. We want to look at strength and support. In this pandemic, for example, here is, people can't travel because of the travel restrictions. People can't travel like before. You can't go and see your families. You have to be doing things virtually. And even if you get to see each other, if you live in the same neighborhood, people can be, like before we see our friends, we want to hug and kiss. That doesn't happen anymore. So all these social concepts, what do we do with that? How do we interpret that? How do we live with that? So here, clearly, also when we talk about strengthening family and community support, who is the target group? People who are more vulnerable, clearly, people who have a high risk, so vulnerable population, migrants, older people who live alone, single house parents households, adolescents, and people with disability, because they may have a higher chance if they're not following the rule, or because of their vulnerability, because of their situations. So what we want to be creating is making sure that we create processes for consultation, develop actions that helps to prevent stigmatization, implement support groups. And who are the people that are supposed to be involved here? So below the pyramid, I have that people will be involved because it's the second level. We're talking about health authorities, health promoter, social worker, educators, so NGOs. You may have Red Cross. So all of these organizations can be involved in this providing support in this at second level. So we go to the third level. So when we go to the third level, so we're talking here is more focus on non-specialized support. So what are the considerations that we want here is to facilitate the access to mental health care and psychosocial support to remote medical care services for the population. So we want to be able to ensure mental health care, psychosocial support for people receiving primary care. We want to actually, again, focus on vulnerable groups and minorities while considering the barriers that prevent access to these services. So you need to ensure working network, social actors training MHPSS, and this is the value of the collaboration with CANPA, for example. At that level here, we are going to be talking more because the people involved in these interventions will be primary healthcare staff, because we're talking about focused person, focus to person, non-specialized support. But then we also want to have MHPSS professionals that are trained to provide support and to provide supervision. So the general consideration here, we want to not only that we have ensure the availability of essential psychotropic, but we also want to establish, database so that we know what's happening, where people are, we can be able to locate them. So this is actually can also go hand in hand with the contact tracing. So target group here, people with mental disorder or people who are much more anxious, people who need to be monitored, who are in quarantine, adolescents, some people who are victims of gender-based violence, frontline health workers because of their work. So not only frontline, but frontline staff in general. So what are the interventions? What are the interventions we're looking for here? We're looking for interventions that are, remote training for first responders. Some of you probably have heard of the PFA, psychological first aid. So this is where it goes. Or some of you probably heard of another tool that we use in mental health, which is the MHGAP, Mental Health Global Action Program. And this program, it is geared toward primary healthcare providers who are not specialized in mental health. And this is because we have very few mental health providers in the region. So we want to make sure that primary healthcare staff, nurses, doctors who are frontliners have some skills in how to detect and manage common mental disorder. So that's at that point, that's when we're talking, this is on the third level. So here, the intervention is to strengthen general health and mental health service network. And this also is an opportunity for to have support groups. So the last level of this pyramid is specialized services. So specialized services, because it's a specialized, so we talk about people who will be involved is professionals who are specialized in mental health. So psychologists, psychiatrists, social worker, here, because it's specialized services. So what we want is to guarantee the access to and continue providing appropriate support with people who have mental health and neurological and substance disorders. The target group is people who are newly diagnosed or who have been diagnosed before. We want to make sure we also provide support to family members, to care. And so this is the target group. And the intervention is access to remote mental health care, monitor psychosocial and pharmacological intervention, training, promotion, and mental health and psychosocial well-being. So this could also apply. So the interventions can be for remote intervention, and prior to the pandemic, it's the same pyramid that applies to a hurricane response, to disaster response. So it's the same thing with the difference here that we're focusing more on remote care. So what is relevant about this? So the relevant is that when you have an MHPSS, is that it allows us to map our resources. Who is where, when, doing what? Unfortunately, we tend to, when we say MHPSS, remember when I was telling you about who is involved, we normally think that it has to be a specialist. But when you think of this pyramid, I mentioned before that at different level of pyramid, all of us are relevant. Our role is important. Why? Because we need to also be able to get proper information, but what are the good public health measures that we need to follow to reduce the curve, to flatten the curve, to decrease the transmission of the infection. So we all have a role to play. So this is why it's so important to understand the structure of the MHPSS. And that when we understand the structure, we also know what are the gaps and what are the opportunities. Or we can identify who are the stakeholders. So you have a country where you have NGOs, we have mental health professionals, we have health professionals, we have Red Cross, we have UNICEF, we have all these agencies. It's important to know what they're doing and how they're doing. So you have one coordinating mechanism. And when you have one coordinating mechanism, that is what that will help you to be able to know where the resources, where's the gap. And each person that comes to the group.
Sorry to jump in, just a quick note to say that we need to start wrapping up.
Oh, okay. So this is my last one. So so we need to make sure that this is an opportunity to set up a response, define key priorities, emphasize coordination. We don't expect that it's supposed to be perfect plan, but we want to make sure that we start from somewhere. We learn by doing. This is what's important, and these are my resources. So this is you'll be able to get that. And thank you very much for your attention. I want to end by saying that there's no health without mental health, and that, as you all know, mental health is everybody's business. So thank you.
Thank you so much, Claudina, for that really great and comprehensive presentation. As usual, we are a bit tight with time, but I would like to maybe open the floor for any burning questions before we move to part two. So colleagues, if you have any comments or questions that you would like to make at this point, please feel free to raise your hand or to type in the chat. We can move to the second part where we are going to be connecting what Claudina just shared with us with the Caribbean context, with the challenges, the opportunities, and the real work happening on the ground. So I would like to ask Peter to take the floor and walk us through the next section of this webinar. And again, if throughout the presentation you would want to make any comments, feel free to type in the chat. Or note your questions, and we will be having that open space for questions and answers after. Thank you.
Good afternoon, everybody. In the interest of time, I will just say all protocols observed, but as representing the Caribbean Alliance of National Psychological Associations, I especially want to thank PAHO for facilitating this process. We are certainly very pleased to finally have a formal mechanism for collaborating, and we look forward to continuing this work together. So the title of my section of the presentation is really looking beyond crises and how psychologists can put the creation of these communities of care, especially in changing times. Next. Next slide. So I usually begin my presentations with just a very quick reinforcement of the fact that, you know, that pyramid and that protocol that Claudina just presented on is a frame and a way of looking at things. But we have to be very careful about how we are programmed to see things. Because part of the reason why we're having this challenge now is that we've been programmed to see things very power-based and pyramidal, so that we have, you know, men and humans at the top and the rest of life going down in priority to the bottom. And really, that is problematic because, in fact, we're all very connected. And we're seeing this now as we notice, as we are, you know, forced to notice what is happening with the climate and with various health crises, most recently the COVID-19 and its genesis crossing the animal-human barrier. So let us keep in mind that as we talk about these different frames of references and pyramids, they're just one aspect of the perspective, and there are other ways we have to look at things. Next slide. So this slide really just highlights the pyramid that Claudina spoke about a while ago, the 4 levels, usually articulating or highlighting that the lowest level is really the majority of the population, and the various needs become usually fewer in number as we go up. However, there are other ways to look at it. So let's move to the next slide. We're talking here now about mental health and psychosocial services, but for many of us, there's a frame of reference that is used by the disaster management and emergency management community, which talks about preparedness, about disasters and the response and relief, the rehabilitation, the reconstruction, and the mitigation. But if we think about it, really, that's very much what many of us do who are involved in mental health and psychosocial services. You know, we help people deal with problems, help them respond, help them rehabilitate, recover, reconstruct their life, and then using what has happened, we help them to prevent further distress or psychological trauma. And we inform prevention activities by helping people and systems and organizations to be prepared. So there's a lot of similarity here. And what we have to begin to understand is how is it that psychologists and those of us who work in mental health and psychosocial services need to conceptualize the role we can play, and also how we can link with our partners who are not necessarily mental health and psychosocial service providers, but have an important and equally specialized role to play on each of these levels of intervention. Next slide. Again, the slide compares the natural history of a disaster and then the developmental continuum. I won't get into a lot of detail here. It's just to remind us that as we conceptualize promotion of mental health and psychosocial services, it doesn't begin with a disaster. There's a pre-disaster phase that includes vulnerability and readiness, and then a disaster and a post-disaster phase. And even within the disaster phase, there can be a latency and an emergency phase. And we're certainly seeing that in the COVID epidemic as it rolls out across the world. It's coming in waves, and people are at different stages, even within the same community or country. So as we think about the mental health and psychosocial services, we have to be looking at it in terms of what are the needs to be met at each of these stages? Who is available to provide the services? Who could be available? And how can we ensure that this can be maintained and sustained over a period of time with primary, secondary, and tertiary prevention? Next slide. As we look at this pyramid, one of the things that I want to emphasize is that very often we talk about who needs support and what is going on inside the pyramid in terms of the general, the focused, and then the more specialized care. But in that protective environment, in that society in which we all live, there's a lot going on also. Now, the thing that I want to emphasize here is that while we look at how we need to collaborate and provide the services, and how we need to move away from having a medical model that only looks at healthcare providers as the primary source of mental health services. We also have to think about the support that is needed by those providers, whether they are mental health, medical health, or other psychosocial and social service providers, because they are usually affected by whatever is going on in the society, whether it's an emergency, a disaster, or a pandemic. Next slide. So as we move beyond the pyramid, we start talking about the different types of services that are needed. At the base, level 1, we talk about, as was mentioned before in the PAHO presentation, things like the resource mapping, the kind of initiatives that help people to know their rights, etc., the administrative and legal support. But we also talk about the services that are needed to share that information, as was mentioned before. So there's an important role to play by all the media practitioners, all the communication officers, etc., who have to develop and disseminate material. There's an important role here also for the psychologists and the mental health practitioners who understand a bit more about behavior and behavior change, mental illness, mental distress, mental disorders. And we have to ensure that we're all engaged together to inform the interventions that take place at that first level. And when we move up to the second level and talk about the community, etc., then there's an important role there also. So while we very often, unfortunately, focus the work being done by psychologists and other mental health practitioners in the top two levels, levels 3 and 4, basic counseling and specialized mental health, there's a very important role to be played by all of us together, and certainly a significant role to be played by psychologists in informing the development of these services. Not the least of which is that we have to make sure that we have the profiles of the individuals who are being targeted, understand how their minds work, understand how their thoughts and feelings and actions are integrated, and then ensure that whether it is a media campaign, whether it is a radio jingle, whether it is a workshop in the community or a webinar, a support group, providing psychological first aid, whichever level we're operating on, it must be informed by the needs of the individual. Next slide. So what is it that we are facing here? And I think there's an issue that we wanted to flag, because while we're trying to create networks and communities that can work at all the levels of the pyramid and that acknowledge the needs of individuals who are providers, not only those in the public, we also understand that there's almost implicit dynamics that go on in these communities that we're trying to create. And we need to name it so we can know it and control it, manage it. Because there's a difference between a community of practice and a community of interest. And I just wanted to highlight that here, because as we move forward and as we try to create this network, this collaboration that moves beyond crises and creates a more sustainable community of care, we need to understand that within the communities of practice, there are certain potential dynamics that are different from the communities of interest, and we need to understand it. Communities of practice are working within our realm. They have different tasks, but they're in the same domain. They're refining a knowledge system that is very codified and can suffer from groupthink, meaning that there are lots of shared belief systems and ontologies. And this is significant because what we need to do is to ensure that those individuals become more participatory in the broader context. And this is meaning, for example, if you're a child psychologist or you're an HR practitioner in corporate Caribbean, and you have a particular field that you're working in, and you might look at a disaster or emergency or crisis through the lens of your particular forte. This is important, but there's a lot for you to learn from the folks from the other communities, a lot for you to teach the folks from the other communities. And so when we move into the concept of the communities of interest, that's where you have the broader frame of a common task across multiple domains. So with regard to, for example, mental health generally, or the COVID pandemic specifically, there will be many different people all interested in responding to this particular issue. And they're going to have an opportunity to synthesize and learn from the integration of the multiple knowledge bases that they have, sharing their understanding, making all voices heard. The problem is that very often the communities of interest don't have a shared understanding as would a community of practice. There's nothing really holding them together except for this urgent need. And unfortunately, one of the problems with that is that the community of interest, A, is not as effective in implementing their interventions, and B, their community doesn't beyond the particular sphere or bubble in which they're operating in response to the disaster. So while there may be a lot of social creativity and diversity, it's all coming from different domains and unfortunately will not last. What we need to find a way to do is to create communities of purpose, is a term that I'm using, that integrates the practice and the interest. How can we ensure that, especially in our small Caribbean countries, where ostensibly it would be assumed that we all know each other and all know what is going on, but we know that very often we operate in silos for a variety of reasons. We have to find a way to move beyond that. And CANPA, in collaboration with PAHO and other agencies, is striving to facilitate this kind of cooperative and collaborative practice. Next slide. So as we move away from the pyramid and we think about the socio-ecological model, most of us will be familiar with the idea that we're going to make changes at the level of the self and the personal with relationships and the community organizations and then the enabling environment, the leaders, etc. So again, if we can create the kinds of partnerships that are informed by the science of psychology, but also informed by the other medical sciences and sociological sciences and by the culture, etc., then these kind of cross-cutting factors are more likely to make our interventions effective. Next slide. Have to protect our providers. And when we did our reviews and analyze the research that has been done, one of the big gaps is, of course, our lack of understanding of the needs of the individuals at each of these levels. And this is not surprising because, as we had noted, very often we see ourselves as healers and curers of others. And also we do not see ourselves as members of a broader community. So resources are not necessarily focused the way they should. We talk about each of these levels, and to the right are some issues that apply at all levels, not only in terms of the arrow and line, but what are the needs of the providers at each level? It's very clear that a group that very often gets committed are those policy and program managers, the technocrats, etc., who have to hold everything together in country while they're dealing with the crises and emergencies, whether short-term or chronic and progressive, dealing with the external providers, external networks and agencies, all coming with good intentions, but these individuals operating at that level are also victims of whatever circumstance is taking place. And it is very important that we begin to understand that we have to build into our support awareness, skills, and interventions to help those who are at the level of the program and policy making, who have to hold things together. Because everybody's affected to different degrees, and our interventions have to facilitate not only other care, but self-care. They're different if you have staff or volunteers, if you are locally based or deployed in by an agency like CDEMA, etc. Unpacking the needs, the mental health and psychosocial needs, is critical, and there's a role for all of us to play, particularly and unfortunately as we look at the COVID pandemic and consider the short-term versus the long-term effects. Short-term and long-term effects not only on our societies and our communities, but on individuals in the community, and then of course on the providers themselves, who have still need to continue and maintain their roles and their efficacy in providing services. Next. So CANPA, in the interest of facilitating this building of communities of purpose that integrate the practices and the interests, has been reaching out over the years, we've worked with international associations, various international associations of psychologists, with MHPSS, the Mental Health and Psychosocial Network that was mentioned earlier, and we really would encourage everyone to go to that website. There's extremely valuable information, guidelines, manuals, etc., available there. As you would know from this particular intervention, we have partnered with PAHO, and the first format for that partnership is a series of webinars, this being the first, and we hope that we will be able to share with you a little more information about future webinars as we go along. We've also partnered with CDMO, the Disaster and Emergency Management Entity for the Caribbean, both in terms of looking at how we can help to support their work in terms of their deployments and their plans for deployment. And there are a number of levels, but I think that of critical importance, of course, is our support for the individuals who are being deployed, whether it is helping to prepare for the deployment in whichever way it is. Their deployment may actually be in their home base, but understanding that if they're entering another country, there are issues around culture, there's socio-political issues that might affect their interventions, and also, of course, besides the other care issues, there are the self-care issues. So we are hoping that as we move along, we know that CDMA is involved with many other agencies and entities in the Caribbean, and that we will be able to partner with them to help to provide this kind of perspective and lens of psychosocial support to them in terms of programs they're involved with. We're also partnering with the University of the West Indies, and this is one which I think is very important for our listeners and participants to be aware of. UE, along with UNICEF and in collaboration with CDMA, is actually doing, in effect, an audit of psychosocial supports providers and systems in the Caribbean. And there is a project manager who is actually doing a desk review, and it would be really important if you were able to make contact. We'll facilitate that so that if there are any reports or documentation you have, lessons learned that can be included in this desk review, it would be very valuable. They're also actually doing a survey itself, an audit, assessing the individuals who are providers of mental health and psychosocial service to look at who is available with what competences. The particular focus for CDMA is identifying individuals who can be deployed in the region in response to any emergencies or disasters. But from the perspective of CANPA, we are very concerned, of course, about identifying all our colleagues and partners who may or may not want to be deployed, but who can become formal parts of the network, and we can continue to collaborate and build capacity. Recently, we did some partnership with PANCAP and CARICOM, and we intend and hope that this can continue. In that context, we were looking at gender and issues around masculinity, mental health and psychosocial support in the era of COVID. And of course, one of the partners who we really are looking forward to working more closely with formally as CANPA is, of course, International Federation of Red Cross and Red Crescent, the Red Cross societies in the Caribbean. Now, it is important to understand that CANPA as an alliance network has formal arrangements, but the individuals who are members of CANPA have a broad range of experiences already in terms of working in disaster and mental health. And I think it is critical that we keep in mind that the alliance is a broader network, but the individuals and national associations have their own scopes of competence and terms of reference that will be very valuable moving forward. And we hope that we can make more links with other individuals and entities in the region. Next slide. So we spoke about regional and international, but at the national level, the national associations of psychologists have all been very involved in developing and collaborating with us to create this particular network. The Disaster Mental Health Committee of CANPA, which I co-chair with Dr. Alice Alves, is the lead in trying to pull together these networks and looking at the lessons learned. A lot of work has been done post-Dorian in the Bahamas, and we must commend them for the excellent work they did in pulling together a multi-sectoral team who created a model there that has actually led to the development of a standard operating protocol that is being finalized now to pull together providers of mental health and psychosocial services, to begin to look at the certification needs, to begin to look at how a country can negotiate with external providers who are being deployed into a system. So there are a number of ways that this is being done. In terms of Trinidad, for example, there is a task force working with COVID, a mental health and psychosocial support task force that includes the Psychological Association and a number of other entities, psychiatrists, social workers, etc. And they're pulling together and focusing on developing a response that integrates mental health and psychosocial services. I know there are task forces elsewhere, such as in Jamaica. You have all the government country teams, you have the national disaster teams. The resources are not that limited on the ground. In fact, I think that we are fairly well resourced. And if we are able to synergize and collaborate more clearly within country and across the region, we'll be far better prepared to deal with what we know is coming in terms of not only the hurricane season, but the COVID pandemic, which, as we know, is a marathon and a progressive process that we are going to have to be prepared to deal with. Next slide, please, Elisa. So unpacking this pyramid a little further, let's move to the next slide. Much of this has been covered before in the presentation by Claudina for PAHO'S. So I'm going to just move across, since in the interest of time, to the next slide. What we're finding is that as we look at applications of the mental health and psychosocial support model across the region, there's so much more that we are actually able to do if we move beyond the narrow confines of seeing it as being about mental health only. And so the importance of evidence-based research, the importance of data that helps us to understand who our people are, what are the issues that are affecting them, their perspectives, and how we can target our interventions. How can we build the teams that can work from the ground up by profiling the various organizations, the mapping studies that need to be done? We have an important role to play in message development and communication. And one of the points that has come up significantly across the region, and Claudina mentioned it earlier, is the need to kind of reposition mental health and psychosocial services away from pathology and towards wellness. And nowhere is this more clear than when we see the stigma and resistance that prevents people from seeking the services because they see it as something that is crazy and bad and mad. And I think an important role we need to play, and all our partners are going to have to play this role, is repositioning this as self-care, as stress management, as promoting wellness, and moving away from the psychosocial. And it's interesting because we did a little survey at one point earlier and found that just that term psycho, which for those of us who work in the field really doesn't mean that much anymore, but for many in the public, as soon as you say psycho, they think crazy, and that's not me. And so there's a lot of work for us to do at that level of raising awareness, ensuring that messages are effective and timely and culturally appropriate. And as we move up and across the because we're not limiting ourselves to this triangle, we're looking at material development, we're looking at workshops and training that are, again, fit for purpose. The technology to do webinars, mass media is there, so interventions are going to be extremely important. And these are the critical things that are going to shape that base of that pyramid, so that when we come to the service delivery, the capacity building, with colleagues, the training of trainer programs, the actual delivery of services to those who have the mental disorders, etc., it's going to be critical. And whether it is a time of a crisis, an emergency, or disaster, there's an important role we have to play in helping people to understand diagnostics and assessment, to ensure that people are not mislabeled, that people get the services they need during these difficult times. Next slide. So some of the observations that we're seeing is that there really is a challenge out there in terms of advocating for mental health and psychosocial concerns. We have too many silos. We create too many individual interventions, whether because of our actual practice or organizations. The territoriality really gets in the way. So again, we're hoping that this collaboration will move in that direction, where we can collect data, analyze, and disseminate, and rather than having things end up in particular projects and programs and files when they could be informing a greater project. Unfortunately, the academic dynamics of public and parish and the funded projects that require reports to go to external providers, unfortunately reinforce this process sometimes. And so the information that should be being used at home base is not accessible to those who are designing programs and implementing programs. And therefore, we have to keep in mind that that research, which tells us about how the different people in our region, whether they are different by age or stage or gender, language, culture, religion, require different types of interventions. And too often we assume commonalities. Everybody's from this particular country or region, and we'll go one size fits all. It doesn't work like that. We know it, and it is going to become even more critical as we prepare for the marathon of COVID. Another issue that has become very clear across the region is the issue of certification. There are many people who care and want to be a part of providing mental health and psychosocial services. They do not necessarily have the competences and are fit for purpose for particular areas of intervention. We have to find ways to identify the competences that are needed, train up and certify those who should be able to provide those services, and be able to monitor and evaluate what is going on across the board. This becomes very relevant when we look at individuals and organizations who are deployed into our region, into our countries, again, as part of larger helping interventions, but unfortunately not necessarily sensitive to our cultures, to the dynamics, etc. And again, this is another role we can play. If we have a combined network and framework, then when people are coming in, we can help them become oriented. Service is as effective as possible. Next slide. So we can move past this slide and move on to the next. This was us highlighting the fact that for COVID, it's a progressive occurrence. And unlike what we've been accustomed to preparing for, which is seasonal challenges such as the hurricanes, etc., this one, as we know from the cliche that a crisis is a time of danger and opportunity, it also is a time that is forcing us to make some choices about how we deal with the bad trouble, as John Lewis has famously said, and engaging in good trouble. And by good trouble here, I'm talking about those of us who have to be advocates. We have to be advocates because we have to make changes. And sometimes the changes we have to make are in systems and organizations that we work in, that we depend on, but that may be resistant to what we're doing. So speaking very bluntly, a lot of the territoriality and some of the personality issues are the biggest barriers in providing the kinds of interventions, designing and implementing and assigning resources. We're going to have to take that role. But the role of being a good troublemaker needs to be evidence-based and informed, because that takes the edge off of the troubling. And if you're giving people solutions by telling them how they can work wiser and smarter, then it is more accessible. And we can move from this whole sprint dynamic into the marathon dynamic. One of the challenges of COVID, and we hope to talk about this some more, is that it is a mix of sprints and marathons, depending on where the virus is, how it is moving, and in what waves. And again, this is an extreme stressor for providers, not to mention the public who just don't understand what is going on. So these dynamic processes require us to manage the perceptions, not only of the public, but of ourselves as providers, and deal with the dissonance that comes up when one belief system is challenged by another. One set of information does not fit with what was taught before. we understand these processes as psychologists and mental health practitioners, and we need to translate that understanding into the messaging and the design of interventions. The next slide. So, for COVID, it's going to affect us at all levels. And really, this was just to make the point of the effects that it's going to have, no matter where you are, whether you're unaffected and think that you don't have a problem, which is not very safe, another very safe way to look at it, through the affected and the worried well and the infected and those who are ill and those who are grieving. We're going to be talking about this in future. So CANPA is really at strategic regional development. We're trying to forge constructive relationships, facilitate communication, collaboration, ensuring that we can coordinate what is going on around all these communities, using the lens that we have from a psychological perspective, but building this common understanding of mental health and psychosocial dynamics as an evolving process that requires intervention from all of us. Next slide. So, future webinars, and we would love to get your feedback on these and others. I won't go through all of them. You'll see some are looking at self-care for responders, integrating mental health and psychosocial responses between the hurricane and COVID, creating networks, partnering with faith-based organizations, the whole issue of communication strategies and message development, research initiatives and how we collect the data, how we can work together to ensure that this data informs our interventions. There's a lot we can talk about and a lot of capacity to be built, and we look forward to partnering with PAHO and other entities to do this work. Next slide. So thank you for your attention again. Please keep safe, and we look forward to collaborating and partnering with you in the future.
Great, thanks Peter for a really great presentation. I really like the concept of community of purpose. I think that's everybody's goal, to ensure that we combine that concept of community of practice and community of interest. I really like that, and I think it frames very nicely what we're trying to do in this space. So I would like to, we have little time, we only have 10 minutes left, but I would like to open the floor for comments, questions, thoughts, reflections. Please feel free to raise your hand and take the mic, or just type in the chat. We really want this platform to be an interactive one, so we're really looking forward to hearing your thoughts, questions, and comments. Just to say, we have 131 persons connected. We are very, very pleased with the level of participation.
Good afternoon. Are you hearing? Morning. Are you hearing me? I was trying to find where to raise my hand and I'm not seeing it.
That's okay. You can take the floor, please.
Okay. Audrey Pottinger. Thank you, Peter, and thanks, Claudine. Just a very quick comment. I mean, I think Peter's presentation and the objective of CANPA in terms of trying to coordinate all of the different organizations that have been working on the ground in disaster mental health over the years is a very tall aim, and I really wish CANPA success with this. There is one, I don't know if it's an omission, but on the slide that showed the different collaborations, whether in the past or those to come, I noticed that there wasn't any on CISMU, the Critical Incident Stress Management Unit of the United Nations. You know, they have UNDSS, United Nations Department of Safety and Security. They have several psychologists and psychiatrists working throughout the Caribbean, South America, Central America in disaster mental health as external mental health professionals and stress counselors. And I thought that is also another organization that you could tap in, because their work is very similar to what you're describing here and the JRC that I'm also a part of, etc. Thanks.
Everybody.
Thanks for that comment. I would like to encourage colleagues to please take the mic or just type. Dr. Thompson is inquiring the name of the organization, so if you can go ahead and type in the chat, that would be appreciated. Any other comments, any other questions? One of the points that Peter raised at the end of his presentation is that we will be continuing these sessions, and we will be reaching out to you with a very brief survey to get your feedback on how you would want this to take place. And so I was just saying that we will be reaching out with a survey to get your feedback about the format and the content, so we can really tailor the sessions that we're intending to hold to your needs and to the format that best suits your preferences. So there's a comment on the chat from Yvonne Armour. Another excellent presentation. Agreed read concepts of the community of purpose. How do our professionals envisage concepts of MHPSS being introduced into the formal education system, into our regional teacher training programs, into our tourism hospitality institutes to sensitize and introduce these important concepts, supporting holistic wellness to provide for earlier intervention? That's a very good comment and reflection. And I think, Peter, you did touch on education. So I don't know if you want to,
Yes.
or comment.
Are you hearing me?
Yes, go ahead.
Okay, so good afternoon, Yvonne. Yes, yeah, very important issues you're raising there, because you're talking about the integration and the synergies that are needed, but you're also touching on the fact that these concepts really should be introduced very early. And I think it goes back to the idea that we're promoting wellness, self-awareness and wellness and coping strategies. Clearly, I didn't have time to go into all of those, but I think that there are ways in which some of these concepts are already being addressed when we look at family life education, when we look at some of the other aspects of the curricula. It really is about having advocates who can help to tweak initially, simply to tweak some of these curricula and to frame them using these kinds of concepts, because they're not alien, they're not foreign to what is being done already. Certainly, there's a lot of more work that can be done to develop additional competencies, especially when we're looking at the challenges that are faced our hospitality sector and tourist industry now, and which they are likely to face for a long time to come in terms of COVID-19 and the pandemic. So I think that, yes, certainly I would agree with that, and there's a lot of work to be done. But there are pieces already, and we need to begin where we are.
I probably can add to that, Elisa. I think I really like the concept that, because when we think of mental health, we think crazy, we think something bad, and the point was very well, delivered in terms of the importance of mental health. So in the schools, we have been, like from PAHO, we've been partnering with the Ministry of Education to be able to start what we call the mental health literacy program. And why mental health literacy? Because you also want to be able to start with the teachers, with earlier in high schools, where we can start to introduce these concepts of wellness, of taking care of your health, of decreasing stigma, of increasing help-seeking behavior, of the mental health, the literacy in mental health at the level of not only for the teachers, but then actually for the students too. And hopefully when we started early from high school, so by the time they go to their tertiary level, it probably can start to permeate. So I just thought we should mention that, because I totally agree the importance of advocacy, of literacy in mental health has to start early, so that we can decrease the stigma and increase more, discussion on wellness. Thank you.
Tara and Claudina. So I'm going to read a couple of other messages from the chat. Barrington Brennan, Bahama Psychological Association, is thanking us for the webinar. It will certainly lay the foundation for continual growth and development. This will facilitate reducing duplicity and collaboration. Thanks for that. And that's, I think, one of the aims that we definitely have, avoiding duplicity and ensuring that we enhance collaboration. Karen Moore is saying, in agreement with Ms. Armour's comment, I would really like to see a webinar on MHPSS and the education system, especially given that young people's school life is most likely going to be disrupted for the next 2 academic years at least. In many territories in the region, children are going to be sent back to school without any attention paid to the mental health effects of their having been out of school for several months. Their shutdown has been longer than anyone else's. We need a plan for MHPSS in the education system to cope with this current crisis and beyond. And here I'd like to say that our PAHO office in Trinidad recently organized a webinar precisely on this. I can share the link to the recording, and Claudina participated in that webinar. So maybe Claudina, if you want to take the floor and comment on this last note.
Thank you, Elisa. We also had that webinar with the PAHO Trinidad office and with the Ministry of Health, and there were staff from UNICEF, well attended. We had over 500 people connected, because definitely I agree, we need to take mental health psychosocial support into schools. So it was a very good webinar. The importance of preparedness before the reopening of schools, and what does that mean for parents, for teachers, for students. We also did similar webinar in Belize with the Ministry of Health and the Ministry of Education, actually well noted. So this is something that's starting to happen. And I think in the discussion, I'm very pleased with the partnership with CANPA, because what we want is that when we do the discussions, so bringing people from CANPA to be part of this. And I definitely see that. So just like CISME want to be part, we want to bring people on board. The more we do that, the better, the more advocates we'll have, especially at the local level, to be able to strengthen the MHPSS. So MHPSS in education, we have started to do that, and I agree with you. Feel free to share, Elisa, to share the website, the link for that recording, the one that we did in Trinidad, and I can share with you the recording that was done with the colleagues from Belize. Thank you.
Great, thanks, Claudina. And colleagues have just pasted the link to the recording in the chat, but I will share when I circulate the presentations and the recording to this particular webinar. So we have a couple more comments. I'll read them out, and then I think we need to start wrapping up because it's already 12:30. So a follow-up to the discussion around education from Dr. Janik Edmond, USA. If we're talking about early intervention, we should begin with infant and early childhood and promoting social and emotional development. We need a Caribbean-specific mental health first aid for lay people and families as part of a mental health literacy. Another comment from Yvonne Armour. I mentioned tourism specifically as being in the unfortunate situation of being the most tourism-dependent region in the world. Our tourism operators are frontline workers whose business is helping to deliver our visitors' dreams while having to deal with their personal mental health issues. The right direction are some of our regional governments that have adopted ministries of health and well-being's capital letters, really promoting good general health and wellness. I think these are all great comments. One couple more, and then really we need to start wrapping up. So Joseph Heron, this webinar is an eye-opener, excellent presentations and discussions. Carolina just spoke about psychosocial support in schools, which is a serious issue. However, access to interventions is a major issue. Many who need it, after getting past the stigma, the cost is a major deterrent. I think that's a very, very relevant comment there. Absolutely, Dr. Janik Edmond. When I refer to education, I refer to starting with the most critical foundational level at the pre-primary level.
Yes.
Great. So these are really great comments. I'm sure there are many more. I really would like to start wrapping up. It's been a wonderful session. I think we've had two really eye-opening presentations, as commented in the chat. Very a lot of food for thought. As I mentioned before, we will be following up the survey to try to identify which are the topics that you would like to see as we move into this webinar series and as we move into really building this partnership for collaboration and for exchanging experiences really as well. So before I finish, I would like to give Claudina and Peter an opportunity to give some final comments or remarks. So Claudina, if you want to start.
Sure. Thank you, Elisa. Definitely thank you for the opportunity to participate and to collaborate with Peter. Since we started the discussions, I've always been interested to share this opportunity with CANPA. And I have been, when I was working doing some work in the Bahamas, CANPA also was members were also present in shaping and starting the collaboration with PAHO in terms of, and with the Ministry of Health, strengthening their MHPSS. So I think this is just one more steps, and we continue working and growing together. As I mentioned in my presentation, we learn by doing. We're not expecting we'll be perfect, but we need to start, and we need to make sure that we continue the strengthening our collaboration. And I also want to thank you, Elisa, from the Caribbean Sub-Regional Office, for the commitment and the effort to bringing mental health to these discussions, and making sure that we send the message that mental health is a cross-cutting issue, and we need to make sure that it is like that. So have a good evening, everyone. Thank you.
Thanks so much, Claudina. Peter, if you want to take the floor for any final comments, over to you.
Well, I too want to thank all our collaborators, my co-chair, Alisa, but also, of course, the team at CANPA and at PAHO. This has been a long time coming, but I'm glad to see that we've started. Creating this community of purpose requires us to have some kind of common understanding, not just concern about the Caribbean. And I'm hoping that coming out of this work, we will be able to identify those things that connect us and that can keep us working together beyond any particular crisis or event. I think one area that we need to work on, and as psychologists we can contribute to, is the whole concept of the behavioral change process, and understanding that we can't just do scattershot interventions. We need to understand the process of change. And once again, the COVID-19 pandemic is providing an opportunity for us to project and think through what is going to be needed over a series of events and processes and waves that we are going to have to prepare to implement in terms of interventions. I did not go into detail earlier, but one of the agencies that we are collaborating with is CAREC, and one of the things we're looking at is working with them to develop specifically structured interventions for individuals who are re-entering the workplace and have to manage their risk for COVID. So again, we need to be able to do the research, get the evidence, ensure that our interventions are designed based on that, they're culturally relevant, they're targeted, and they're strategically placed so that they develop a set of competences that will help us to develop as a region. I look forward to contributing and participating and learning more from my colleagues as we proceed.
Great, excellent. Thanks so much, Claudina and Peter, for those final words. And I'd like to also thank the colleagues at CANPA, Ava, Alisa, who have been working with us on putting this session together and really launching this collaboration. So thanks a lot. We will be following up soon with the presentations, the recording, the links to other webinars, and that brief survey, which would be really, really important for us that you take a few minutes to complete so we can really tailor the sessions to your needs. So with that, I would like to close today's webinar. I think the one thing that stuck with me is this building communities of purpose. So with that aim, we'll continue to work together. Thank you, colleagues, and have a great rest of the day.